Assalamu alaikum. This is Kisa Zahra Zaidi, roll number BP1650108, group number 57. And the topic of my presentation is acute cluster seizures. So basically, what are seizures? They are sudden abnormal or unusual electrical discharges from the brain that results in changes in sensation, behavior, movement, perception, or consciousness of a person. They are formally known as an epileptic seizures. Seizures are basically not disease themselves, but they are basically symptoms of many different disorders. During a seizure, there could be uncontrolled shaking movements involving much of the body with loss of consciousness, or shaking movements involving only part of the body with variable levels of consciousness, or to a subtle momentary loss of awareness. Seizures may be provoked and unprovoked. Causes and pathophysiology of seizures. In a normal physiology of brain, there is a constant electrical stimulation and inhibition every second of the brain activity. When there is a constant excessive excitation or inhibition due to any malfunctionality of ion channels or due to genetic abnormalities or structural lesions like brain tumors, traumatic brain injury, infections, and perinatal brain lesions, or any metabolic disorders, a seizure will occur. Diagnosis of seizures. Neurologist evaluation. It is based on family history, witness of occurring episodes. Electronic encephalogram (EEG). It is basically a test to measure brain activity by placing small sensors all over the scalp. A computer generates visual representation of brain waves, indicates about any imbalance in brain activity. Acute apparative cluster seizures. It is basically not listed in the International League Against Epilepsy (ILAE) Commission on Classification and Terminology. So this clinical entity is also called as flurries, cyclic, serial, repetitive, and recurrent seizures. A broad definition of seizure cluster is acute episodes of deterioration in seizure control. It is basically more than standard normal seizures. Risk and consequences. Some patients with epilepsy are at higher risk to develop seizure cluster than others. Epilepsies with risk factors are refractory epilepsy, extratemporal epilepsy, symptomatic generalized epilepsy. Seizure clusters are dreaded because of their association with status epilepticus, which is potentially life-threatening. Seizure clusters can result in increased emergency room visits or hospitalization. A person should call for help when the person has trouble breathing or is choking. A person having seizures asks for medical attention, or someone without a history of seizure has one, or seizures occur one after another, or seizures occur closer together than normal, or a seizure lasts 5 minutes or longer. Management. Benzodiazepine class is prescribed in the management of cluster seizures. The choice of drug is rectal diazepam, and the other drugs are lorazepam and midazolam. Diazepam is basically preferred because it exerts anxiolytic, sedative, muscle relaxant, anticonvulsant effects on a person experiencing a cluster seizure. It also acts on the GABA receptors. Case study. BN, a 7-year-old 28 kg boy, has had seizures since age 3 months. He suffered anoxia at birth. His seizures usually involve initial confusion and disorientation, shortly followed by generalized tonic-clonic convulsive activity. Despite treatment with carbazepine at maximum tolerated doses and serum concentration, which is 300 mg thrice in a day, he continues to have approximately 2 seizures monthly. Recent trials of topiramate and diagabine as additions to his carbazepines were unsuccessful and caused intolerable sedation and lethargy. During the past year, he has been admitted to the emergency department (ED) 5 times because of seizure flurries, consisting of 3 to 6 seizures occurring over a period of 12 or fewer hours. While he regains consciousness between these flurry seizures, he becomes lethargic. During ED admissions, IV diazepam was administered. This was rapidly successful in terminating seizure activity. BN mother relates that she usually can identify the onset of seizure flurries. BN's behavior changes and he becomes clingy and whiny and hyperactive. She also indicates that the initial seizure in a flurry differs from BN's typical episodes. Before the onset of generalized seizure activity, he experiences much briefer periods of confusion. In addition, the generalized seizures are longer and more severe, often with dramatic cyanosis, and at beginning of flurries. What factors about BN predict successful use of such treatment? How can it be administered? Soap notes. Subject 87-year-old gender male, chief complaint seizure flurries. Medical history: BN has had seizures since age 3 months. He suffered anoxia at birth. Anoxia is basically an extreme kind of hypoxia where the brain experiences a severe deficiency of oxygen. Seizures usually involve confusion and disorientation followed by general clonic tonic activity. BN was treatment with carbazepines, which is an anticonvulsant, and the dose was 300 mg thrice in a day, but he continues to have usually 2 seizures monthly. Recent trials with topiramate and diagabine with carbazepines were unsuccessful and caused lethargy and sedation because topiramate and diagabine are also anticonvulsants. So it was an adverse synergistic effect. Last year, BN was admitted to ED 5 to 6 times due to flurries. IV diazepam was administered, which controlled the seizures occurrence or terminated the seizures. Object: BN physically is a healthy child with normal growth and daily activities. Initial seizures in a flurry differ from BN's typical seizures, experiences much briefer periods of confusions. Generalized seizures are also longer and more severe at the beginning of the flurry. Assessment: BN's relatively frequent flurries or clusters of seizures are causing him and his family significant difficulty. BN continues to experience seizure flurries despite on carbazepine therapy. He responds well to IV diazepam and has a caregiver who can identify the onset of seizure cluster. But by staying at home, we can't administer IV diazepam easily. So, for the plan, we should have something, an alternative, which is much more effective and easy to be administered in an emergency situation. All of these factors indicate that a trial of home administered treatment to avoid these cluster episodes is likely to be helpful and should be initiated. Soap notes plan. So, a drug of choice should be rectal diazepam gel diastat. BN's mother should administer rectal diazepam gel at the onset of identifiable cluster seizure activity. A dose of approximately 0.3 mg per kg, 10 mg should be given and repeated if necessary within 4 to 12 hours of the first dose. When diazepam gel is administered rectally, it is absorbed relatively rapidly. Peak plasma concentrations occur in approximately 1.5 hours and is often effective in terminating cluster seizures within 15 or less minutes. A caregiver can recognize the onset of cluster seizures which are different from a patient's usual seizures activity, and when the caregivers can be trained to administer the preparation safely and to monitor the patient's response, example respiratory status following administration. Because diazepam has many adverse effects such as respiratory distress or sedation, etc. So there should be a vigilant monitoring of the patient who has been administered diazepam. Ben's mother should be counseled on the administration of this product and given the patient package insert which gives complete instruction for the administration of rectal diazepam. After administration, BN should be monitored for at least 4 hours to ensure that no respiratory depression or other adverse side effects are occurring and to assess the effect of the medication of his seizures. Most common adverse effects seen with rectal diazepam is somnolence, occasionally accompanied by dizziness and ataxia. Respiratory depression is very uncommon. Thank you.